Okay, so this is going to be part 3 of the TBI lecture. So hopefully I haven't put you to sleep yet. Just a little bit more about deficits and then a few rating skills. Sorry about the dog interruption there. So let's share my screen. Here we go, it's a bigger. Let's get my bad face out of the way. Here we go. Okay. So communication deficits, other impairments, just like strokes, they can have, TBIs can have aphasia, either expressive or receptive or global, both. This can affect their, just like with strokes, this can also affect their expression and reception of writing information as well as reading information. So that part of their language can be knocked out too. Language skill deficits such as dysarthria. So remember, aphasia is a problem in the brain forming or understanding words in the brain. Dysarthria is trouble making the words, articulating them with your mouth. So it's a problem with coordination of your lips, your mouth movements, and your tongue. Visual perceptual deficits, just besides vision problems, there can be visual perceptual impairments. These are particularly going to be present if there's any damage to the cranial nerves or to the occipital lobes. And if you have blindness because of damage to the occipital lobe, then it's called cortical blindness. That means there's nothing wrong with your eyes and the nerves going through your brain. It means your occipital lobe in the back of your brain, which processes all of your vision, was damaged, and now you can't see. But most of the time with brain injuries, they're going to have spatial neglects or right-left discrimination problems or just vision deficits. So we'll talk about discrimination problems in a minute. Oops, wrong way. Nope. So I'll talk about, there's a slide coming up with that in a minute. So we talked about the hemianopsia or cortical blindness with strokes. TBIs can have it too. They can have spatial neglect, where that's usually a problem with right-sided brain injuries, usually right-sided brain injuries. Sometimes it can be of the left, but it's almost always of the non-dominant hemisphere is where we have our visual and spatial, kind of like our depth perception is controlled there, and abstract thinking and flexible thinking and like creativity. People that are big authors and creative storytellers probably have an artist of any kind. Musicians, painters they use their right hemisphere a lot. Those are all the things that a lot of the things the right hemisphere does on the frontal lobe. And so when you have a problem over there, you're going to have a problem with depth perception, maybe even knowing what's up and what's down and what's right and what's left. You may completely what we call left neglect, and you may forget the entire left side of your environment and only pay attention to the right side of your environment. And you may not understand what that means, but literally these people do not see the right side of their world. They only pay attention this side. And you can stand, and one of the ways you work on that is you always stand as the clinician on their left side and talk to them, because you're trying to force them to turn their head and look at you. Now, it's very, very hard. Most of the time, they're going to tell you, I don't know where you are. I can hear you. I just can't see you. And then you can try turning their head to the left, but they're going to fight you because to them, you're making them fall. So it's a very strange phenomenon, but it's very fun to work with sometimes. You learn a lot from that. Swallowing deficits, a lot of them are going to have dysphagia, trouble swallowing because of problems to the cranial nerves or just motor control deficits. Poor posture. Let me go back to, yeah, swallowing is done by speech therapist. Let's go back a slide. I missed one word. Under visual perceptual impairments, there's this term called apraxia. Now, don't get that confused with ataxia with a T. This is apraxia. Okay. Now, this is a motor planning and spatial prop impairment. Okay. So this is almost always going to occur when there's a right-sided hemisphere lesion. And there's speech apraxia, there's motor apraxia, there's different types of apraxia, but the most common type of functional apraxia example I can think of would be if you're working with a patient on their upper extremities and you're working on reaching for objects and then putting on, say reach for a table and then put it on this table. You may tell them, I want you to take your left hand, grab the cone, and then put it over here on the table. Well, they may look at the cone and think, I'm trying to do it. I've done it before. I know I can do it, but there's a disconnect between their brain and the muscles and nothing happens. Well, then you just move on. Well, then 10 minutes later, you're not even asking them to do that same task, and they just are maybe helping clean up, and they just grab the cone and move it over there like nothing ever happened, and then like there was nothing ever wrong with their arm. That is a type of apraxia. It's very, very strange. Sometimes it has something to do, I don't understand it completely as well as speech therapists and OTs do, but it has to do with motor planning, motor execution, and the thought process of it. And when you have a lesion on the right side, then you can have apraxia. We talked about swallowing and dysphagia, indirect impairments, contractures. I mean, if they're not moving their joints through the right range of motion, if we're not doing it for them, then they're going to develop contractures and they might have to have surgery to release those. Skin breakdown can happen to anybody that loses mobility. They can have DVTs, HO. That's HO, if you don't remember, is bone forming in a place of the body where it's not supposed to, like inside of a muscle belly or in a joint, and fuse the joint. Muscle atrophy, decreased endurance for almost all of them because they're not up and as mobile, most of them, unless they're very strong. And infections and pneumonias from having poor posture, sitting in a wheelchair a lot of their day. They can get lung infections and pneumonia. The majority of the last part of part 3 is going to be on rating scales. We talked a little bit, you might have saw some of these scales in the last little bit. Let's talk about these. The Glasgow Coma scale is a scale that's used by first responders on the scene when they're picking people up and testing them, and in the ER. It's a scale that goes from 0 to 15, but the lowest score you can get is a 3, so I guess a 3 to 15. And it's basically just giving you a coma and a brain injury score in that moment. So at this time when they get to the scene, the paramedics get to the scene, they're going to score you on these attributes. So this is what they do. So there is a motor response, a verbal response, and an eye opening. And I'll let you look at these, and you can see, even if you don't do any, you get scored for each category. The highest you can get is a 15. That means you're doing everything spontaneously and you're oriented and you're obeying commands. The more damage you have in your brain, the lower you're going to score. The worst score you can possibly get is a 3. And that means you are definitely in a true coma. Now, this will change throughout the first few days. They'll continue to do these tests on you because usually in the first few days of a brain injury, lots of changes are going to occur. So they're constantly doing it to retest you. And hopefully your score should go up over the first few days. The Galveston orientation and amnesia test is a test that was developed at UTMB in Galveston, and it's a national test that everybody uses to measure post-traumatic amnesia, or PTA. It's a score, you get scored from 0 to 100. 100 is a perfect score, and it's a standardized test that's done verbally by the neuropsychologist about your orientation to person, place, and time. And the higher your score, the better, the closer you are to getting out of post-traumatic amnesia. And scores of 76 to 100 is considered normal, and it's considered that the faster you get to that normal score, it's a predictor of a good long-term outcome. The longer you stay in post-traumatic amnesia, that's predictor of a poorer outcome. Okay, this is a long scale, the Rancho Los Amigos levels of cognitive functioning. This is the same Rancho Los Amigos that came up with the GATE names, and now they came up with a TBI behavioral scale. This is a scale it ranges from level 1 to level 8. And these are the names of them. There's a very long and, well, I will say this, I will explain it like this. No response is the lowest you can score, and that's a 1. That would be a true coma. No eye opening, no response to pain, pinprick, external rub. Generalized response might be you respond to pain, pinprick, or sometimes you have your eyes open and sometimes closed, like a sleep and wake cycle. That's a 2. Localized response would be maybe you have sleep and wake cycles, and maybe sometimes you can follow a command occasionally, maybe inconsistently, but occasionally. Something like, can you squeeze a person's hand? Now, that could just be a reflex. A lot of times people will hold a loved one's hand and the hand squeezes back. That a lot of times, honestly, that's a primitive reflex. That's the grasp reflex that reemerges from infancy. But if a person can go from a relaxed hand to squeezing a loved one's hand, and they can do it, say, 4 out of 5 times on command, or 3 out of 5 times on command, and on command is the key term here, then that is a localized response. They are responding they can do one thing almost all the time. And it gets better. The cognition and the motor responses and motor recovery gets better as you go all the way through level 8. If you'll look in big red, there is a very a very detailed explanation and examples of each of these levels. You will be tested on these levels on your test with several case studies. So you will have to be able to tell me what level somebody's in. Okay. If you have trouble remembering, now don't think that when you move, some of these levels, you might be reading the definitions and they'll sound similar. They do bleed into each other a little bit. And there is a little bit of overlap between every one of these, but there are key differences for each of them. And as a person's brain is healing, generally you want to see them go from level 1 up the scale to level 8. Now, there may be days when they are on level 3, and then they go to level 4 the next day, and then they take a little bit of a backslide, and they go back to level 3 for a few days. But then they jump back to level 4, and then they stay there for a week, and then they'll go to level 5 for a week, and then they may show a few signs of level 4 for a few days, but then they're back at level 5, and then they go to level 6. So that happens a lot. So you can change levels and you can go backwards, but usually if you go backwards, it's either because it's just the natural healing and you're going to automatically come back from it, or there could be an infection, there could be increased ICP pressure, you could have a UTI that could be causing your cognition to be different, or anything like that could cause your cognition to change. But yes, do know these very well. The Rappaport Disability Scale is just a scale of functional behaviors and skills that we use to that we can use to score somebody on functional activities like self-care things. The Glasgow outcome scale is related to the Glasgow Coma scale. It's the same people that came up with the Coma scale, but this one expands on the original scale to include major categories for disability. Here's some links you can look at. I'm gonna speed through these a little bit. This is just what happens. We're gonna talk about what happens in the different stages of the care now. So we're not going to be involved in this care and most of this stuff, but like at the scene of the TBI, they're going to do CPR. They might have to intubate them for an airway. They're going to stabilize their neck and their spine, because if there was trauma, there could also be a spinal trauma too, very likely. A lot of times they do spinal injuries and brain injuries can happen at the same time from the same accident. At the hospital, they're going to be doing x-rays, CT scans, MRI scans. They're going to stabilize their vitals. They're going to monitor and try to stabilize their intracranial pressure. They're most likely going to keep them sedated if they're not sedated, because they need to keep them calm in order to keep them from danger and putting themselves in any more danger. HOB stands for head of bed. They're always going to keep the head of the bed elevated at least 30 degrees, so that they don't aspirate on their own saliva, or if they start to vomit or anything, which is common after increased ICP vomiting, is then they won't choke on it. So you can look through all this. This is how they monitor for increased ICP. They actually do cut a hole in a little round hole in your skull, and they stick this little probe down through your brain, between your gyri into a ventricle, and that little thing has a little pressure sensor on the bottom that monitors your ICP in your brain. So it is kind of invasive. Hopefully you're asleep if they have that in you. More things that they do in acute care. They work a lot. Everybody's got to be on lots of seizure medication, because seizures are all a seizure is just an abnormal electrical activity in the brain. Well, if pathways have been disrupted in the brain from an injury or lesions, then you're going to probably start having seizures. Not immediately, maybe not, but within days or throughout your rehab, you are going to have seizures. So these people are going to be on a lot of seizure medications. They're going to have a lot of urinary tract infections, just because they may have a neurogenic bladder. They may have trouble going. They may retain urine. Their blood pressure could be high or low. They'll be on medications for pain, depression, lots of seizure medication, medication for enhancing cognition, medication to control their cerebral edema, medications to improve their arousal and their attention. There's all kinds of medications that try to improve arousal and attention, so they'll try to do that. We come into play a lot with positioning and contracture management, and then in the acute care setting. And then we're also in the acute care setting, we're getting them out of bed as soon as we can. Trying to do it as soon as they're medically stable. So they may still be in the ICU hooked up to tubes, but we're still talking to them. We're still doing exercises in bed. A lot of times we sit up on the side of the bed and work on sitting balance. Some people even stand in the ICU. Sensory stimulation, that's a lot of times for the lower level cognitive patients, those people that may be in a minimally conscious state. You may do sensory stimulation with pinpricks, with certain sounds to get them to try to turn their head or turn their eyes certain direction. Some recreation therapists that I used to work with used to use essential oils, and they would take different smells that the person liked, like chocolate or peppermint, and they would put the smells up to their nose and see if they would react to that. And a lot of times they would give them a smell that they knew from their family that they liked, like something that smelled like food, or something something nice like flowers or mint or lavender, and then they would open their eyes in response to that. So that's a type of sensory stimulation. So that is a way of stimulating the brain. So if they open their eyes in response to a smell or to a sound or something, we're stimulating the brain. I've already mentioned pretty much all of this. A little bit on the rehab members. Remember that the patient and the family is no matter what setting you're in, acute, inpatient rehab, which tends to be a long phase of stay, and then outpatient, which is a very long phase. The patient and family has always got to be at the center of everything. They're the most important person or people in the whole our rehab continuum, because what's important to their lifestyle is what we've got to teach them to do again. We're teaching them to do things to get back to be independent in their life again. We're teaching them how to manage their spasticity and their impairments. We're teaching them how to stretch and get stronger, because even when they go home, they're still going to have these impairments. We've got to teach them how to manage them, because this is likely going to be a lifelong situation for them. And you can't be in therapy the rest of your life unless you're rich. So you've got to learn how to manage and do these things on your own. So that's where good home exercise programs come into play. And start your HEPs on day one, even if they're in acute care, and you just graduate and update them every few weeks as you go along. So if you've never known, your team member. Let's talk about the team members. The physician that is a rehab physician is usually called a physiatrist. That's their specialty, or PM&R for physical medicine and rehab. They go through years of residency and then years of fellowship, and they usually specialize in spinal cord injuries or brain injuries or neurodegenerative diseases like Parkinson's or MS or orthopedic rehab, things like that. But they're rehab doctors. Then we have speech language pathologists. They're going to not do just talking and communication, but they're going to work on swallowing and cognition too. We've got occupational therapists and OTAs. They're very much the same job we do. They just work a little bit more on functional and cognitive things than we do, and they do a little bit more things with dressing and getting dressed and self-care and bathing than what we do. But they can still do gait training, they still do strengthening, they still use modalities. If you see an OT and a PT working side by side in a gym, you may never know the difference. And that's okay, because we are very much alike, and we should work with our OTs a lot, as well as our speech therapists, because we learn from each other and we can carry over our skills for our patients if we all are on the same page. Rehab nurses are nurses who are specialized in rehab needs. So they know how to, they know about rehab specific medications, spasticity meds. They're really good at helping bowel and bladder program training, because a lot of times after a stroke, brain injury, spinal cord injury, you have to retrain your bowel and bladder all over again, just like from a kid. You're going to have a case manager who can be a nurse, or they can be a social worker most of the time, or any other healthcare professional, but they're going to be your liaison between the healthcare team or the hospital or the facility and the insurance company. So they're going to be talking about they're going to be telling the insurance company weekly or monthly or daily the progress the person's making, what's going on that day, medical procedures they're having, and those kind of things. And they're essentially your cheerleaders for you, because if you have a problem with the insurance company, your case manager is who's going to go to bat for you to try to get you more days or more money that you need for your patients. So make good friends with your rehab nurses and make good friends with your case managers, because if you ever need anything, then they're going to be the people that help you out. Social workers, if they're not if the social workers are not the case manager, then they're going to be there for patient and family education, and they do a lot of counseling for the patient and the family. They're very important for that. They help them because this is a traumatic time for them. All these changes to their life and their and their health status and their thinking. So they do a lot. They have to start off on a lot of counseling and new coping strategies, and they often refer them out to counseling for more long-term needs when they get out of the hospital. Neuropsychologists, we've already talked about, they usually work on behavior and memory in the hospital or the clinic. Then you've got respiratory therapists that work with people that have breathing needs, get them off of ventilators. We have music therapy, which, if you don't know what music therapy is this awesome type of therapy that is especially helpful with neurological therapy. I'm not even going to pretend that I know how to explain 1% of it, but people react to music in ways that they'll never react to you and trying to do exercise. I've seen music therapists get people to speak for the first time when speech therapists couldn't. I've seen music therapists get people to open their eyes and turn their head for the first time when I tried for weeks to do it. I've even seen music therapists help me get a person to take a person's first step before. So they can do, the brain is very wired for music. And I've learned this from music therapists. Music is wired throughout the entire brain, where most things in the brain are localized to certain lobes. Music goes through the whole brain. So that's why music is so popular. And you can think in every culture from ancient civilization, we've always had some type of music, and it's very calming. People like it to get energized, to calm down, to work out to cry to. So music becomes very emotional, and it ties in very, very, very strongly with physical rehab too. So try to learn about those. If you ever happen to see it, work with the music therapist, learn all you can from them, and they're going to blow your mind with what they can do. Recreation therapists are therapists that do a lot of group game and outing activities with patients. So they may do, like, a lot of times they'll do wheelchair basketball for patients recovering. They may have a pet day where they bring in pets and patients play with the pets and work on physical skills like standing balance while they're playing fetch with the pets, or they may work on gait while they're doing something in the game. A lot of times recreation therapists will co-treat with other therapists, and we'll go on community outings. So like we may take a brain injury group out to, we used to go to the Target once a week with a different group every week, and with a cognitive group, and that was kind of like starting to get some executive functioning skills back. So we would give them a budget. Every patient had a budget, like usually $10, and they had a list of certain things that they had to buy, and they had to find the things in the store. They had to get to the register. They had to know how to pay and and if they were getting the correct change. So that was a very fun community outing. Sometimes very difficult for patients, but it was very eye-opening. But it taught us, you might think they're doing well and they're making gains, but then you put them in a real world situation, an outing, and then you really see how they work. So recreation therapists are very valuable in getting our patients into the real world before they're discharged. Product predictors of outcome in the brain injury world, very difficult to predict. Your cognitive and your behavioral outcome improvement is the speed at which that comes back is actually going to be the biggest predictor of the person's overall outcome, but also their motor and their physical outcome. Because if they can't pay attention to you, and if they won't listen to you, and if they want to participate with you, then they're almost never gonna make physical gains. So if they can get their cognition and behavior getting going and healing, then they're more likely to make physical gains too and have better participation. So this is just something about coma. If they're in a coma for more than 2 weeks, that's just a predictor of moderate to severe disability. If it lasts for less than a week, moderate or minimal disability. With PTA, obviously the greater the time in amnesia, the worse your prognosis overall. So pretty much they've come up with these cutoffs down here. If you're in PTA for greater than 12 weeks, it's gonna have a worse outcome of disability. And then if it's less than 4 weeks, then you have a better outcome of disability at a year post. But you can see this 98% of patients experience PTA, 98% at least. Just active goals, I mean, no different than any other patient you're going to treat. We're going to do a lot of balance, maybe more balance than you're used to. There's going to be a lot of attention and behavior training. There's going to be a lot of safety training. There's going to be community reintegration training. So things that probably as a new grad, you're not going to really know anything about it. So you're going to have to just learn that. You're going to have to ask your OTs. You're going to have to ask your speech therapist, your neuropsychologist, your more experienced PTAs and PTs. How can I work on their attention? How can I keep their attention when I want them to do this? A lot of times you have to just step back from what you would consider a normal exercise routine and just do things that are important to them so that they'll participate. So like if you know their hobbies are playing cards or blackjack or poker, so you can put them in a standing device and lock them in and then make them weight bear on their affected arm while they play cards with their unaffected arm. I can't tell you how many times I have done weight bearing and standing tolerance while playing blackjack before. It's a game, but hey, I'm working on weight bearing through all of the affected extremities. I'm working on tolerance to standing upright when they're usually in a chair most of the time. And we're doing a cognitive activity because they have to count the 21 or know when they've went over. So they have to make decisions. So that's just an example. We used to play Connect Four with people for a lower level cognitive function. It's almost like tic-tac-toe. You've never seen it, but you play with checkers on a vertical board and they have to get 4 checkers in a row. And your goal is I would always let them get 3 in a row and then I would block them with one of my checkers. And then I would always wait to see if they would catch me before I blocked them or if they would see that I blocked them and if they even noticed at all. If they didn't even notice at all and they just kept on going, then I wouldn't keep the game going much longer. But as far as physical things go, it's going to be any kind of orthopedic strengthening you've learned to do before, any kind of forced use you've seen us do before. So far in lab that we've learned in lab on the videos that we've already done that you have or haven't learned. Basic PNF diagonals, PNF, advanced PNF, any kind of gait training, any kind of resistance training. You can lift weights, pull resistance bands, ride bikes, upper extremity bikes, lower extremity bikes, body weight supported treadmill training, gait training. Where this says dual task performance, have them doing 2 things at one time. So if they've gotten really good with their balance when you're working with them, now have them count backwards from 10 while they stand on 1 foot. Hold on to them with a gait belt because they can stand on 1 foot for 10 seconds or 30 seconds without losing their balance. But now that you have them count to 10 backwards, they might lose their balance. Or if you have them turning their head while they're side to side or up and down while they're keeping their balance, they may lose it. So you're adding more things. You're doing 2 things at one time. Lots of instruction and education to the family and the caregivers, whoever's going to be, and the patient too, because they're all a team working together. So before that patient is left out of your care to either go home or go to the next level of care, it is your job to teach the family and or caregivers or everybody involved how to do everything, because eventually if they're leaving you, they've got to keep this up or the patient's going to regress. So we talked about neuroplasticity during the stroke lecture, and you've seen a good video that I posted on it. Basically, use it or lose it. The brain responds to repetitive stimuli, but if you don't use it, you're never gonna get it. You'll never gain it, or you'll lose it if you don't use your gains. Once you do get it, the more you repeat in it, the better you'll always get. Even years after an injury, you can still get better at impairments and gains. Repetition matters, intensity matters. So, once they get stronger, up the intensity, up the weight, up the reps, just like an ortho patient, just like you learned from Dr. K. Time matters. Yeah, we've got to start really quick. You can't have a brain injury and just sit around for months and months and months feeling sorry for yourself and letting things heal and then start therapy. Nope. You got to start right away, because if the brain goes a little while without any kind of challenges, it's going to start shutting down even more. And then your window for neuroplasticity just is going to shut down and not even be there. Age matters. Younger brains heal and are more plastic than older brains, just naturally. Transference means taking a skill or a motor ability and using it in another setting. It's kind of like generalization of a skill. I think this is our last little slide. So this just talks about really just mild TBIs or concussions, thought to be more metabolic in nature, but they can cause these things. Shouldn't ever return to sports for at least a week, even if a concussion is just suspected. You need to have a thorough neuro exam by either a trainer that works for your organization that knows how to do a neuro exam, and then send you to a doctor, or you need to have the neuro exam done by a doctor. It needs to be, but somewhere a doctor does need to be seen, especially if there was a loss of consciousness. If you have any for blurred vision because of it, any change in posture, any forgetfulness, especially big signs or nausea, vomiting, light sensitivity, and ringing in the ears, get yourself to the doctor ASAP. And you need to rest physically and cognitively until all of those symptoms resolve. So these coaches are like 1 or 2 days after rest, you're going back to practice or back in the game. No, they're only keeping these players' brains from healing. We used to have a concussion protocol for sports, for a certain, can't remember the school district. We used to do their sports concussions for all their high school teams, but we had a certain template, or not a template. We had a certain protocol we went through, and we always challenged their symptoms cognitively and physically with exercise or cognitive challenges. But as soon as their symptoms started coming on, whether it's a headache, dizziness, forgetfulness, impaired balance, or a little bit of nausea, we stop everything, go to an empty room and lay down in the dark. Doctors even say that you don't even need to be on a cell phone, on a tablet, until all the symptoms go away, because of the blue light from our screens nowadays can cause a lot of strain on our brain. So you're not supposed to do those things either. We went through those, so these are just some case studies you can go through on your own. So that was 3 parts for TBI. So hopefully it made a little sense, and hopefully it helped breaking it up. So let's put it all together, get in lab together, and we'll do some activities. But send me some emails if you have some questions, or catch me in lab. Okay, thank you.